One thing that we have talked about a lot, and we've done a lot of work in our clinic with this, is osteoporosis from these drugs. And generally what we try to do, you know, in some of them, if their bone density is low enough, generally less than -1.5 or 2 in a T-score, is that we'll offer them some sort of resorptive therapy, you know, like zoledronic acid, you know, reclassed, or denosumab, Xgeva, or Prolia.
Right.
And the big issue with that is that I think for nurses that are listening to this and other docs, you know, is that it has to be coded properly. Remember, this is our big problem. You know this, we run into this a lot, is that, you know, this is for prevention of cancer therapy-induced bone loss. It's not for osteopenia, not for osteoporosis, because there are a strict set of criteria to get payment for these drugs. And if you put it in as osteoporosis, then oftentimes insurers won't pay for it. You have to really put it in. And if you know, we've talked about this. I mean, we've run into this problem occasionally in our practice.
And of course, the patients who are on the this family of drugs, we have them take calcium with D daily.
Calcium with D daily, exactly. That's a big thing.
Weight-bearing exercises.
Weight-bearing exercises. Watch their mouth, because there's a very small incidence of what's called osteoporosis of the jaw. It's very uncommon. But when we put people on that, because they've read it on television, they've read it or seen it on TV, it's like the first thing they think. You know, you put me on this drug, is my jaw going to fall apart? Have you had that conversation with people?
Perhaps once or twice.
Yes, perhaps. She's laughing because she actually has had that conversation. I know, because I'm at the other end of that conversation. So the thing is that, you know, so these are things that people worry about with hormone receptor positive breast cancer. But the nice thing, though, is that the vast majority of people with what's called luminal A, low risk hormone receptor positive breast cancer, will survive. We're talking like, you know, 97% 5-year disease-free survival, probably 95% 10-year survival. I think the vast majority of people are going to be absolutely fine, which is great, which is really a cool part of our business.
How do you determine whether to keep a patient on 5 or 10 years?
It's a great question, and it's a question you get all the time. I think that, you know, the reflex was always to say 10 years, well, aromatase inhibitors is another story, because the data is still very uncertain. You know, we did a big trial, NSABP-V42, where women got 5 years of aromatase inhibitor versus 10. And statistically, there were no difference between the 5 and the 10-year arm in terms of disease-free survival, but there were numerically fewer recurrences in the 10-year arm, so we're kind of trying to figure out who should get what. That's unknown. So right now, most people get 5 unless they really want to stay. Just like you said, they don't want to stop. And we talk about the risks and benefits. The risks are, you know, arthralgias, osteoporosis, that sort of thing. You know, but the benefit is reduced recurrence. Most of those recurrences turn out to be in the breast. So if a woman's had a bilateral mastectomy, I probably will tell her not to do it. Okay, that's number one. Tamoxifen is a different story. So tamoxifen, there seems to be benefit. In fact, I remember when they came around, they did this trial called Atlas. This is before you came into our practice. You know, this must have been about 15 years ago. They came to us asking us to participate in it. And what they did is they had women who were on 5 years of tamoxifen, and then it was not even a randomized trial. They just said they offered them another 5 years, and then they recorded what happened to them. And it turns out in that trial there were fewer recurrences in the 10-year group. But the problem with that is that you get more blood clots and endometrial cancer. So, you know, I've really kind of dialed back a little bit. I don't give it to everybody anymore. What I tend to do now is if someone is at high risk of recurrence, you know, someone who, you know, has a lot of lymph nodes up front, a big cancer when we first started, you know, I probably would think very strongly of giving that. It's the same kind of people that, you know, who are premenopausal. You know, I don't give LHRH agonists like Lupron or Zoladex to everybody, as you know, unlike my colleagues and even in my own practice. You know, because I just think that the side effect profile of those drugs tends to be a lot harsher for the benefit you get. And so basically it's someone who really is at higher risk. You know, someone who had a lot of lymph nodes, had a big tumor. Those are, as you know, who I tend to give LHRH agonists to. The same people I tend to give 5, 10 years of therapy to.
Have you ever had a patient say, can I be on Arimidex forever?
Absolutely, I have a lot of them. And there was a trial called MA17R, which had women who were on tamoxifen for 5 years. Then they got I think, letrozole for another 5 years. And then they randomized them to nothing or another 5 years of letrozole. And the people who got an extra 5 years of letrozole had fewer recurrences, mostly in the breast, but they had a lot more osteoporosis. So yes, I had a woman actually come back. I've had her in my practice for almost 13 years, and she wanted to continue. Yes, they want to continue forever.
Well, as the nurse, we make sure they get their DEXA scans every 2 years.
There you go. That's an important thing to do, especially in this era where, you know, we're pushing back DEXA scans to 2 years, 3 years, 4 years. Insurance doesn't want to pay for it. So, you know, what we're trying to do now is say, look, you know, you really kind of, this is a big problem. You know, what I don't want to do is prevent a new breast cancer, but at the same time have you have a bone fracture. Right. You know, and so this is very, very important. But again, I think my colleagues around the country have differing opinions, But for me, I tend to really reserve like the long-term therapy for people who are at a higher risk of recurrence. We have some genetic tests, genomic tests, like what's called BCI, and now there's another one, EndoPredict, to a lesser degree, that can kind of tell us who's going to recur between years 5 and 10. We are starting to use those tests to kind of help us. I think they're not widespread, and it's just hard to know because insurance doesn't like to, because they're expensive. Insurance doesn't like to pay for them. So, it's interesting to see how we're going to do this. So you asked a great question. It's a tremendous question, actually.
Thank you.